Well, thank you, everyone. Welcome. Good morning for some of you, good afternoon for others, and welcome to our webinar series, Advancing Data, Policy, and Prevention for Service Members, Veterans, and Their Families. Want to welcome you all in. We have a great presentation for you today, focused around veteran families and caregivers, understanding the needs, roles, and economic impact. And we have Daniel and Kelly here from RAND, who are going to give some great presentations. And I just have a few slides before then to cue things up. So next slide here. All right, and welcome to everyone again. Maybe this is your first time as a part of this webinar series, but thank you for joining us. My name is Phil Patty. I serve as a project associate here at SAMHSA Service Members, Veterans, and Their Families Technical Assistance Center with Policy Research Associates. I'm happy to be your moderator for today and to help take us through the presentation. Next slide. All right, a little bit of a background on SAMHSA. SAMHSA leads public health and service delivery efforts that treat mental illness, especially serious mental illness, prevent substance abuse and addiction, and provide treatments and supports to foster recovery while ensuring access and better outcomes for all. Since around 2008, SAMHSA has partnered with states and territories to strengthen those behavioral health systems, serving our SMVF, providing TA through our SMVF TA Center. Next slide, please. Okay, I won't get through every single one of these, but you can see in front of you, and you'll have a copy as well. These are some of those services that we do provide in technical assistance, whether it be monitoring evolving trends, with our behavioral health focused prevention with the states and territories and local communities we work through, training tools and consultation teams for on-site coordination, strategic direction there, sharing, of course, evidence-based practices across our states and territories, supporting some of the implementation of those pieces. And as we do work with states and territories, being able to then identify experts and resources to continue that work into the future in those implementation steps, and also the training of some of those SAMHSA partners and grantees on some of those issues. So that's a little bit about us. Next slide. And then here as well, some of those activities that we do it through. Webinars where we are today, and we have some of our other such resources as well, which I would encourage you, if you'd like to learn more and be a part of more things, to go to the samhsa.gov SMVF TA Center webpage. And there you can get onto our listserv and our monthly email roundup to stay connected. Next slide, please. All right, and just a little bit about RAND here. RAND is a nonprofit, nonpartisan research organization that helps improve policy and decision-making, conducting rigorous evidence-based research, providing data-driven policy recommendations, supporting federal, state, and local decision makers, and working across sectors, including health, national security, education, veterans policy, and social services. And our partnership with RAND dates back to 2017. In support of these technical assistance efforts, RAND has been a great partner for ourselves as well as our teams as folks look to be able to measure and kind of continuously improve our processes as we do embark on some of our strategic directions we're all taking. Next slide, please. Okay, and our learning objectives for today. Number one, understanding the composition, such as number of children, age, income of veteran families and households and how they differ from civilian families and households. Secondly, identifying potential mechanisms for engaging with veteran families. Next, describing the prevalence and characteristics of military and veteran caregivers, including key differences in well-being outcomes between caregivers and non-caregivers. And finally, explaining the direct and indirect economic impacts of military and veteran caregiving, including the estimated uncompensated value of care and implications for policy and program development. Thank you. Next slide. And with that, I will go ahead and introduce our two great speakers today. We have Daniel Schwam, Senior Quantitative Analyst with the RAND organization, as well as Dr. Kelly Hyde, associate economist with RAND. And with that, I will turn it over to Daniel.
All right. Hello, everyone. As I was introduced, my name is Daniel Schwam. I'm a senior quantitative analyst at RAND, where I do research on a number of topics, among which I focus on veterans with a particular interest in their housing insecurity. And this research that I'm going to be presenting to you today is about veteran families and households in America. This report, which is available on RAND's website, was published back in 2024. Looks at takes a dive into some public data to try to describe what veteran families look like. And so with that, next slide, please. Next slide. And just from that backslide, this research was funded by the Veteran Policy Research Institute at RAND. And so the motivation for this project basically comes from the fact that within recent decades, there's been a push by the Department of Veteran Affairs to expand their focus beyond veterans to their family members and caregivers. There's a long history of research for active service members and how active service impacts their spouses, their children, whether it's their mental health or their employability. And so when active service members transitioned to veteran status up until recently, those family members were no longer the focus of the VA and their research. It honed in on the veteran and the struggles that they face. So this research project really wanted to just start the conversation about what veteran families look like. What are some of their economic characteristics, their social and demographic characteristics, to try to understand the challenges that they face. Next slide. And because of because families are integral to the military life. I mean, we often think of active service member families as part of the active service members' survivability is not the right word, but their experience. They rely heavily on their families. So naturally, extending to veterans, they rely heavily on their family as well. Whether they be bringing in economic resources to support a larger family group, or whether or not they rely on them for caregiving services. But as I said, this is a pretty new research area, and we don't really know much about what these veteran families look like beyond their active service. Next slide. So what we're going to do is we're going to use some publicly available data, specifically from the American Community Survey, to look at a snapshot of these families. So this report uses data from the 2022 American Community Survey, which is an address-based survey of about 3 million addresses in the United States. It can get pretty granular in terms of its detail. We know a lot of information about all the family members and potentially non-family members, whether or not they're in the house at the time of the survey. And so there's a really rich treasure trove of information here about each family member, the incomes that they earn, their backgrounds, their educations, anything you can pretty much think of. It's probably going to be in the ACS. And so for this particular report, we're going to look at family composition. So whether a veteran lives with a domestic partner, whether they have children or other family members in their house, what their racial and ethnic backgrounds are, because that's going to speak a lot to their stories and their lived experiences, what their average age looks like, as well as their employment status and their income levels. And like I said, because all family members are captured in this survey, we'll be able to look beyond just what the veteran brings to the household. Next slide. So to start, there was a bit of a tricky thing we needed to do, which was to define what a veteran household is. For this particular report, given that, like I said, we have a detailed family structure in the survey, we identified a veteran household as one in where the person responding to the survey, which the survey calls the head of household, or their spouse, if they have one, is a veteran. Now, this is going to leave out some families So you can imagine a head of household might live with a parent who is a veteran, or they have a child who is a veteran who's living with them. But we wanted to focus on households where the primary decision makers are, where at least one of them is a veteran, because that's really going to drive their economic situations. So with this definition in mind, we estimated that there were about 14.7 million veteran households in the United States in 2022 that fit this definition. So it's about 15 out of 130 million households in the US. Next slide. And one of the first things, like I said, we dive into, because it's part of the definition, is whether or not there are more than one adult, whether it's the head of household and the spouse, that are present. So what we found is that veteran households are much more likely to be in a two-adult household. So there's the head of household and their spouse or partner, compared to non-veteran households. So what this is really going to mean is that any policy geared towards veterans is going to have a much broader implication, because it's going to impact at least one other, more likely to impact at least one other person, even though it's not a direct impact. So it's important to look beyond the veteran themselves, because any decision made or policy directed at the veteran is going to have broader sweeping implications. And this is compared to about 52% of non-veteran households that are two-adult households. Next slide. So the composition of veterans is changing, but as of today, veterans typically are older households. And we define the age of a household based on the older of the head of household and their spouse if they have one. So if the head of household is 65 and the spouse is 50, that household will be classified as a 65 plus household. So more than 50% of veteran households are 65 or older, compared to about 25% of non-veteran households. And this is going to have implications, because certain policies might be dependent on whether or not there are kids present, or your employability, or whether or not you're bringing in Social Security. So looking at the age composition of these households is an important factor in how policy will impact them. Next slide. So just to break down, so we know a little bit more about the age of these veteran households, about 33% served during the Vietnam War, 22% served between 1975 and 1990, and then 15% are veterans of more recent service period after September 11, 2001, which is how the American Community Survey designates the post-2001 era. So each of these veterans is going to experience different complications and different challenges. But just so we know a little bit about when these veterans served, we break it down by their service era. Next slide. So looking at the composition of these households beyond whether or not there's a spouse in the house, the next natural question is whether or not there are children present. And because veteran households are older, they're less likely to have a child present in their house. Whether they have children or they don't, they're probably more likely to have aged out and be above the age of 18. So this slide just shows us a distribution for veteran and non-veteran households, how many kids are present. And like I said, this is going to have implications, because economic resources are going to need to be directed towards whether or not there are children present in the household. And so it will have a direct impact on whether or not a household is doing well or struggling, or whatever challenges they might face. Next slide. So one of the major things we're able to look at in this study is when veterans get married and who they're married to. This is a really interesting facet of the American Community Survey. So for married veterans, we found that 65%, so about 2/3 of married veterans, are married to non-veterans. About 30% or 29% are single veterans. And then the remaining 5% are veterans that are married to other veterans, or veterans who aren't married but are in partnerships. And partnerships are defined a little differently in the ACS. It's a bit more difficult to identify who the partner in the household is, but we know whether or not they are married versus in a partnership. And as I'll be able to show in a little bit more detail in a couple slides, this is important because when veterans get married may have implications for what their spouses may or may not know about like the active military life or what it means to be a veteran. They may not have much exposure to that lifestyle, and they may not be aware of the policies that and programs that are available to them. So I'll have a bit more detail on that in a couple slides, but this is the one of the main findings of this report looks at who veterans are married to and when they get married. Next slide. So what's also interesting is that in recent years, the ACS has introduced questions about opposite sex and same-sex couples. And so we're able to identify amongst the married couples which ones are in same-sex or opposite sex relationships. And what we found is that if the veteran is a female, they're more likely to be in a same-sex relationship than male veterans. And this has a whole host of implications for lived experiences and potential economic outcomes. And so it's one of the things we were able to unearth about veteran couples in this survey, which was really interesting for us to learn. Next slide. So this is a busy slide, but this, as I mentioned just a few slides ago, is going to talk. This slide talks about when veterans get married in relation to their service. And I want to draw your attention to the bottom bar graph, which specifically looks at married veterans. And so what we found is that more than half of veterans that are married in our survey got married after they left active service. So this speaks to what I said earlier about being married to non-veterans. Their spouses may not have the experience of being in an active military family, or be aware of the programs and policies that are available to them. And so this drives at a potential policy mechanism for communicating to these non-veteran family members certain programs that might be available to them, whether it's helping them find a job or support programs for their children. It speaks to how we might want to derive policies about communicating veteran policy. And compared to active duty married couples, most of them get married during the ones that are currently still on active duty, most of them, because they're currently on active duty, were married during their service. So it's more likely that those spouses are aware of the policies and the lifestyle associated with being in the military. Next slide. So one of the interesting things about veterans is that they are becoming more diverse. And so this slide breaks down by service era the share of veterans that are minority, which is non-white, and the share that are male versus female. And so what we see is that as we progress in service eras, as we get to more recent service eras, a larger share of veterans are minority status or female. So for the post-2001 veterans who served after 2001, about 40% are minorities and 17.1% are women. And again, this is going to speak to lived experiences, so that when we design policy, we don't necessarily want to use one mechanism that might not address a specific demographic. It's important to look beyond just when they served and at their specific demographics to understand what challenges they may be facing. Next slide. So this is my last slide, and it's pretty detailed, but this slide dives into the employment success or the economic success of veteran, civilian, and active duty households. So because we know we have surveyed every member of the household, we can calculate each member's employment status, whether or not they're in the labor force or not, or whether they're employed or unemployed. And we also know their individual economic contributions to the house, so what their wage salary income is, if they're bringing in income from other benefits. And so the groups of bars are split by civilian households, active non-dual, which means that there is one member of the household that is active service. There's veteran non-dual, where one member of the couple is a veteran, and then veteran dual, where both members are veterans. And so we have income split by whether or not both members are employed, whether one is employed and one is unemployed, whether one is employed and not in the labor force, because there's a distinction there. If you're unemployed, you are looking for work but unable to find it, whereas not in the labor force, you're not actively looking for work. And then we also have an income bar for whether or not for the group that is where one member is unemployed and one is not in the labor force. Both are unemployed and both are not in the labor force. And what we find is that across all these employment status combinations, veterans earn more, they bring in more money than their non-veteran, than their civilian and active duty households. And this could be because they earn higher wages, which we do see there is a premium for veterans in the labor market. It could be because veterans might be bringing in additional income sources, whether they have disability or they are maybe just, well, whether or not they're bringing in disability. And so veterans are more economically secure when when we look at income from all their sources. And that's important to remember because your income is going to affect your, if you are earning less, but your income still affects your ability to potentially participate in other public programs like SNAP. So things like your disability income might impact your eligibility. And so what we found this interesting is still the veterans have this premium that they earn. So there is an economic reward that comes after service. And so overall, we found that about 12.5% of non-veteran households fall below the poverty line compared to only 6% of veteran households. So there is additional economic security to having a veteran status. Next slide. So as I said, that was my last slide. So what can be done with this information? Like I said, we want to find a way to reach as many people as possible to make sure that they know about the programs that are available to them. And so as we learned from this presentation, for example, veterans mostly get married after they leave the service to partners who have not been in the service. So increasing communication to those non-veteran partners is going to will really increase engagement. And it is an important way to make sure that people are aware of the resources that are available to them. Next slide. I guess I mentioned this already, but yeah, so we want to be able to get the word out to targeted family members about the benefits that are available to them. Next, I think there should be another point on here. Yes, and then we want to be able, as I mentioned, we looked at the changing demographics of veterans. We want to be able to make sure that we're capturing the different lived experiences of veterans based on more than just them being a veteran. It could be because they come from a minority household, or it could be differences between men and women and the economic opportunities they have. So it's important that we take these factors into consideration when designing policy. Next slide. And then one thing that also would be interesting is that we want to study further is whether is looking at two veteran households and then the dynamics of these households. Next slide, please. Next point. So this is just some information about our leaders at the Veteran Policy Research Institute, if you want to follow up or learn more about the research that's being done at RAND. So thank you so much, and I'll pass it over to my colleague, Kelly.
Hi, everybody. Are we wanting to move forward with the next presentation or do any Q&A separately for Daniel's presentation first?
Yeah, we can. There's a couple of questions that came across in the Q&A pod there, Daniel.
Okay.
So I know one attendee asked, has a comparison of households falling below the federal poverty line been conducted with the National Guard or active duty population specifically?
Yeah. So let's see. Yes, I'm just rereading the question. So this research was done doing the American Community Survey. And within that survey, unfortunately, we don't know the service branch for the individual. So using this survey, we can't get that level of granularity and look at members of the National Guard or the reserve. But it is an interesting question, and I think it can be done if we had. I think there's a lot of, I don't want to say private data, but I'm sure there's data out there where we could do this breakdown and look at members of different service or whether or not they're in the reserve to see how well economically they are doing. But for this study, we weren't able to do that because the ACS does not have that level of granularity.
Thanks.
So I was going to address the next question, which says, are the stats addressing first marriage only or just identified after as married someone after service? That's a great question. So this survey looks at an individual's most recent marriage. So we can't whether someone's married, we can't tell if it's their first or actually that might I can't remember the specific questions. We know the year they were married. I don't think we can tell whether or not they have been married before. So it's just in reference to their current marriages, which could be first, second, third. So let's see. Okay. How would Congress? So the next question is, how would Congress's efforts to cull veterans' benefits affect these figures if they are actually enacted? That's a great question. I haven't looked into too much about what those cuts are going to be, but if they're if we're thinking like a cuts to disability benefits, it's going to bring down the veteran household's income and potentially drive them below the poverty line and make them more susceptible to things like recessions. So I actually have done some other research that looks at the current makeup of like how disability income impacts household security, and it's big. So if there are things like cuts to disability benefits, then we can definitely expect economic security for these households to be worse than it was before. And that's obviously not what we want for this group. So disability benefits and other monetary benefits definitely play an important impact in their security. Okay. Do you think, so the next question is, do you think the difference regarding same-sex households holds a stigma for men who are? I'm going to refrain from answering that question. I am not a part of that. I don't necessarily do research beyond just what these households look like and what the experiences of same-sex households are. So I don't know too much about it in military life. So I'm going to refrain from answering that question. Okay. I have another question about how veteran race ethnicity percentages have changed over time. Do we know if those changes mirror demographic changes in the overall general population? We did not look at it for this study, but it is something we can definitely calculate. And if it's something you're interested in seeing, I'd be happy to follow up and help you learn more about how those changes in the U.S. population compare. But for this study, we haven't looked at those. And the last question is, the slide showing era of service only counted for 70% of veteran households since the Vietnam era. Can you clarify the remaining 30%? Are they all pre-Vietnam? That would make 30% of veterans, 75. Yes. So so there is a group of veterans in the survey that are pre-Vietnam era. So the ACS also has I think the term for this service area is the Korean War. Then there's one in there that's a years-based distinction. It doesn't actually have a name. And then there are World War II veterans. So they do make up still a sufficient chunk of the remaining veteran population. We saw that veterans are older, and there are still a non-trivial share of veterans in that group. So we focus mostly on the Vietnam, the 1975 to 1990, I think it was, and then the post 2001 era. Those are the largest shares of the veteran population that we still have. But thank you for all those questions, and I'm sure we can share my email information if anybody has follow-up questions after the presentation if they want to learn more. So thank you so much.
Thank you so much, Daniel. All right, and I'll hand it over to Kelly.
All right. Well, thank you all for joining us. It's an honor to be with you today to share the results of our research. This work also took place under the Rand Epstein Family Veterans Policy Research Institute, same as Daniel's presentation project. And this was also sponsored by the Elizabeth Dole Foundation. I also want to like set the scene in terms of on Daniel's last slide, he mentioned our VPRI internal leadership. The work that I'm going to be presenting on today was led by Rajiv Ramchand. And so I was very focused on kind of the economic components of it. I'll be sharing the full breadth of results with you, but just want to give credit where due. Rajiv was definitely the intellectual leader for a lot of this. So just keep that in mind. And also, it was a very large team, which I'll mention a little bit later. Next slide. And yeah, this is just the title slide. One more thing I want to mention to kind of transition from what Daniel spoke about. A lot of the results that we're going to be talking about from our project tell somewhat of a different story with respect to economic security and insecurity particularly. But it's important to keep in mind that the sample size and the population of in focus differs. So while Daniel was speaking to the entire population of veteran households, for my presentation, for the results that I'll be sharing with you, will be focused specifically on households where some regular caregiving activity is being performed to meet the caregiving needs of a military or veteran caregiving recipient. So just keep that in mind as you kind of think about the contrasts and the similarities between our two presentations. Next slide. So, dialing back 10 years, or I guess 12 years now, at the time, this was also published in 2024, like Daniel's report. So at the time, this project was a 10-year revisiting of a topic that Rand had worked on previously. So in 2014, Rand published a report called Hidden Heroes, America's Military Caregivers. And this shed light on the work that these hidden heroes, these caregiving providers do. And this was kind of considered a 10-year look back of what's changed, what has evolved, how has the policy landscape changed in the interceding 10 years. So this is a long kind of arc of research that Rand has been engaged in for several years. Next slide. A lot has happened since 2014. So the veteran population that was studied in 2014 has aged. The US withdrew from Afghanistan, and so the composition of veterans within the US changed in terms of the era of service that they had. And also, the COVID-19 pandemic impacted all of us, the population. It created new types of caregivers and also had new types of heroes as those around us took on some extra risks during the pandemic and kind of continue to deal with some of the after effects of that to this day. But this figure is just showing you a broad summary statistic of how the American veteran population has aged. And then, as you notice in the x-axis, it goes on to 2040. So that's also inclusive of projections of how that might evolve over time. So from 2000 to 2021, the share of American veterans that are 65 years of age or older increased by 12 percentage points. So that's a pretty substantial shift, almost half of the veteran population as of 2021, based on census data, was 65 years of age or older in 2021. That is expected to decrease somewhat, partly because of the changes in the policy environment that I mentioned previously, but still remain at an elevated level relative to 2000. Next slide. There is some good news in terms of what has changed since 2014. There are several things that have improved, and some of these things happened in response to the 2014 study that Rand published. So most notably, the VA, in part because of legislative mandates that took place in 2014, has expanded offerings to caregivers, including things like respite care, peer support mentoring, skills training, coaching, and also for some caregivers, a financial stipend, legal support, and health insurance as direct economic and social supports. There's also an ongoing pilot offering telemental health for caregivers, which is pretty unique in that historically the VA has only provided health services to veterans, but there's growing understanding of the need for caregivers as well to have access to similar types of services. Also, in addition to the VA's efforts, there have been some other advances. In November 2023, Center for Medicare and Medicaid Services created new billing codes that enable Medicare to pay healthcare providers to train caregivers to carry out a particular treatment that their caregiving recipient needs. This is a really noteworthy advance because it's among the first set of billing codes that pays for services delivered to individuals other than the patient as another kind of support mechanism. And then finally, many nonprofits have created or expanded their services to provide direct care, like respite or emergency financial assistance, training for caregivers, peer support, or advocacy on behalf of caregivers and their caregiving recipients. Next slide. So 10 years later, we took a new look and we published this report in 2024, Americans' Military and Veteran Caregivers, Hidden Heroes Emerging from the Shadows. And this was, as I mentioned previously, a broad team. There were several new researchers that joined RAND in the 10 years between the original report, including myself. But there were also some return members, and Rajiv particularly led both efforts. So there was continuity there as well. Next slide. One of the main findings that really headline findings of the 2024 work was advancement on this question of who is a caregiver. So the kind of older methodology or the previous methodology, which is very typical of the literature, used a single self-identifying question to identify caregivers. And so the question exactly on the survey was, do you provide unpaid care and assistance for or manage the care of someone who is at least 18 years old and has an illness, injury, or condition for which they require outside support? So this survey question relies on self-identification as a caregiver, and one of the things that can be a concern with that is that might not capture everyone. That kind of gets into the variation of how people interpret the title of caregiver, and so we set out to explore. Are there individuals who are not being captured by this question, but might be captured as caregivers by other survey means? Next slide. So this was the new approach. So all of the results that I'm going to be sharing with you today are produced from a large nationwide survey, which was administered in 2023, the RAND Caregiving Survey. And one of the innovations that it had over the 2014 report was that it switched to a task-oriented approach of identifying caregivers. And so these tasks that you see on the slide are the tasks that individual survey respondents were asked to report whether or not they regularly conduct. So we identified caregivers as anyone who reported doing any one of these 7 broad caregiving activities within the past 30 days as of the date of their survey response. So these include things like helping individuals into and out of chairs, bathing, administering medications. It also includes things like helping those with dementia remember things, driving people to medical appointments and then waiting there to drive them home from the appointment, Military and veteran caregivers help arrange for medical appointments and psychological services, but many also help manage the mood or anxiety of those that they are caring for at home on a continual basis. So our approach was casting a wider net to say, even if you don't, regardless of the way that you respond to being asked directly whether you are a caregiver or not, if you are engaging in one of these activities regularly enough that you did so within the previous 30 days, then we consider you a caregiver. Next slide. And the result was kind of consistent with our hypothesis. The result was a much larger number of caregivers than were identified in previous efforts, including the 2014 RAND survey. And so we found with this task-based approach that almost 41%, or 105.6 million US adults, are currently caregivers to other adults. And that's inclusive of both military veteran and civilian caregiving recipients. When we drill down to just the military and veteran caregiving recipients, that number is 14.3 million, a share that is roughly commensurate with the share of veteran households that Daniel shared in his presentation earlier, just talking about the composition of military and veteran caregivers and caregiving recipients. But still much larger number than was previously found. And this has wide-ranging policy implications in terms of the population that needs services, the population that is impacted by the impacts, both positive and challenges of caregiving. And so this is really one of the main headline findings of the more recent work. Next slide. It's also important to remember that the experiences of caregiving are very individual. So, one of the components of this project, beyond just the survey, was a series of qualitative interviews that were conducted with both caregivers, and then also medical teams and other individuals involved in the care of a particular caregiving recipient, staff and personnel at the facilities at which they receive that care, etc. And from one of the direct conversations with a spouse caregiver to a Vietnam War Air Force veteran, included this insight that she said, I can tell you that my experience has been the same as everyone else, but my experience has also been different from everybody else. And anyone who's a caregiver will tell you the same thing. We all have the same experiences, but we all have very different experiences. So this speaks to the idea that there is a common core of experiences that are shared across caregivers, but there are also very individual, unique experiences that are relevant to an individual's daily experience, daily life with providing caregiving support to an individual. And that's kind of where we'll expand on this with the findings about what those caregivers are experiencing in aggregate, and what the policy implications are. Next slide. One way that you can see the variety of experiences is in the relationship caregiver has to the person that they are caring for. So the quote on the previous slide was a spouse caregiver, but that is not universal. There are caregivers that are all different relationships to the recipient. So if you look at the top bar, we also break this out between the age of the caregiving recipient, because we see some interesting dynamics at play there where it does matter what the age of the recipient is. And we use a cut line of 60 years of age. So if you look at the top bar, almost half of the caregivers that we identified through the survey are a child or grandchild of the caregiving recipient. About a quarter are spouses. Also, about a quarter are neighbors, friends, or other non-relatives that are connected to the individual, but not necessarily related. And then only 1% are parents for this demographic. We would expect that just by age and sort of that dynamic. And then 12% of them are other relatives that were not otherwise categorized in the bar. When we look at 60 or under caregiving recipients, much smaller rates of caregiving by children or grandchildren. Again, that's kind of just mechanical from the age. A similar share of spouses, about 24%, 27% neighbors or friends or other non-relatives, and then a larger share of parents and other relatives providing these caregiving supports. So this just speaks to the idea that caregivers are not a monolith, and the types of supports you can design supports that are effective for spouse caregivers, but not necessarily effective in the same way for a child providing caregiving services. And just being mindful of that as we design policy is important. Next slide. So our research identified four key areas to better support today's hidden heroes. And we're going to address each of these in turn. The first one, for each of these, we created a series of recommendations as well. So the first area is addressing the economic impacts of caregiving. I'll talk a little bit more about what exactly those are on the coming slides. We also discussed opportunities to strengthen programs that support caregivers, ways to create a more caregiver-inclusive healthcare system, and then finally, conducting rigorous research that can address critical gaps that we identified over the course of our own research published in this study. Next slide. So first, I'm going to talk about the economic impacts of caregiving. Next slide. The first thing that we set out to do was to quantify the value that is being generated by caregivers in terms of like household labor. If we kind of try to put a cost on this in terms of if similar types of activities were performed in the labor market for a wage, what would that magnitude look like? To get a sense of what the degree of uncompensated economic value really is. And the reason why that range, so we found a range of estimates, which is pretty broad as an interval, ranging from $119 billion to $485 billion. The reason why that range is large is that caregivers are engaged in a range of different activities that would be expected to command different wages on the labor market. So some activities such as like transportation, for example, to and from medical appointments. We might think of that as, in terms of the typical wages earned by individuals engaged in those activities on the labor market, maybe something closer to the state minimum wage, wherever that caregiver resides. But then there are also activities that are like administering medications, managing a medication regimen, a treatment schedule, et cetera, that would be more commensurate with like the activities of a home health aide, a nursing assistant, or all the way up to a registered nurse, when we particularly get into that administering medications level. And so this range just represents the full spectrum of possibilities from applying each of those wages in turn. So we don't apply specific wages to individuals just because there is so much individual variation in what activities they're engaged in. But instead, we present this range of saying if you consider the proxy one of these four options, here's the range of possible values that you would estimate for the uncompensated economic value that's being generated by these caregivers nationwide. Then we turn to the cost side of things in terms of what are the explicit and implicit costs that are incurred by caregivers as a result of their caregiving activities. And we broke this out into two main categories. The first was annual out-of-pocket costs. And we had particular particular categories of that were informed by previous work done by RAND and also by other organizations such as AARP in terms of quantifying housing costs, out-of-pocket medical expenses, those types of cost centers as major drivers of these out-of-pocket costs that caregivers face. And then we also looked at impacts on the labor market, and this is more indirect of there's a kind of, in economic terminology, there's an opportunity cost to caregiving activities where any time that you spend on caregiving could theoretically instead be spent on a wage earning labor market activity. And that's how we quantify like the foregone earnings, not just in that kind of opportunity cost framework, but also we observe evidence of adverse consequences faced by caregivers in terms of disruptions to their work schedule, like passing off promotions or other job opportunities because the needs of the caregiving recipient kind of constrain their ability to move or to take on additional responsibilities at work. So we call these work disruptions more broadly, and we had different ones that we elicited. And rolling all of that up, we then use those work disruptions to try to estimate what's the aggregate difference in earnings in caregiver households as compared to those households that are not engaged in caregiving. So that's what we mean by foregone earnings in that context. And when we add these two things up, so we found an estimate of about $8,600 in annual out-of-pocket expenses that were self-reported on the survey, and then an additional about 4,500 overall average estimated annual foregone earnings, which culminates in over $13,000 of average economic impact on caregivers. So the story here is that there's a one-two punch of caregivers are engaged in demanding, challenging activities to support their caregiving recipients that are typically not compensated in the way that they would be on the labor market. And also, the direct impacts on their finances are actually measurably negative in that they incur out-of-pocket costs that are not reimbursed, and they also forego earnings on the labor market, all of which affects their financial security and their financial well-being in the household. Next slide. When we look at more qualitative measures of financial well-being and financial security, we also find that caregivers face increased risks of financial hardships. So when we look at the poverty line, and this is maybe where we draw the clearest contrast with Daniel's findings looking at the overall population, when we zoom in on just military and veteran caregivers, we find quite a high rate of being below 130% of the federal poverty line, 35%. So over a third of these households are in poverty based on that 130% measure that is used in the administration of many public programs. We also see high rates, particularly among those caregivers that are providing services to younger caregiving recipients, which is an interesting finding that resonated throughout our survey. So, in terms of self-reporting difficulty paying bills as a qualitative measure, we see elevated rates relative to the baseline, and I want to draw your attention to the legend here in the bottom right corner of the slide for interpretation of the figure. The gray bars are non-caregivers. So those are individuals who were not identified as a caregiver based on our task-oriented approach on the survey. The salmon light pink colored bars are are cases of caregivers to a caregiving recipient that is over 60 years of age. And then the red bars are caregivers to caregiving recipients that are 60 years of age or younger. And so you see that for difficulty paying bills, both subgroups of caregivers are reporting higher rates of difficulty paying bills than the non-caregiver comparison group, but that's particularly pronounced among the 60 and under caregiving recipients. Two-thirds of those households are reporting difficulty paying their bills, which is pretty striking as a result. When we look at a different qualitative measure of does the household consider itself to have kind of a rainy day fund or emergency savings? Do you have a base of money to tap into if need be? The not quite as stark a contrast as the difficulty paying bills measure, but still consistent with that pattern of increased among the older caregiving recipients relative to the non-caregivers, but increased even more among the caregivers to the younger caregiving recipients. Next challenge. Sorry, next slide. So our recommendations to address this are twofold. First, we recommend educating organizations that are serving caregivers to be more aware of programs that caregivers might be eligible for. So this is something that Daniel also emphasized in their recommendations. So such as Supplemental Nutrition Assistance Program or SNAP to address challenges accessing and paying for food, for example. And then second, we recommend that policymakers explore caregiving tax credits. And so this was more recently, this has been a top legislative priority among groups such as AARP in terms of an economic policy mechanism to try to reduce or even offset and compensate for the adverse economic impacts of caregiving that we observe. Next slide. The next set of recommendations that we develop and the body of evidence that we create relates to strengthening programs that support caregivers. Next slide. So caregiving takes a toll on the caregivers. Among military and veteran caregivers caring for those 60 years of age or under, represented by the light green bars in this figure, 22% of them have had thoughts of suicide in the past year, and 43% meet diagnostic criteria for depression, which far exceeds the rates among non-caregivers, which are represented in this figure by the orange bars. So obviously from a kind of whole person perspective, these things are related in terms of we're observing worse mental health, more warning signs of mental health challenges among these caregivers to younger caregiving recipients. And then also in the previous slides, the financial insecurity, the difficulty paying bills, et cetera, those things are interrelated. It was beyond this study to try to identify any kind of causal relationship in that, but we definitely see a strong association between those things that is very localized among the younger caregiving recipient households. Next slide. However, despite these higher rates of mental health symptoms, many caregivers report wanting but not accessing mental health treatments. So, our hypothesis going into this was that cost was going to be the primary barrier to this. But among the highest risk caregivers, who are those caregivers to younger caregiving recipients, the main barrier that they reported was actually time. They don't have enough time to get treatment. Many also had concerns that if they admitted to having these mental health challenges, they might be involuntarily hospitalized, and that might prevent them from continuing to provide the care for their loved ones that they are currently providing. And so, again, this kind of contrast that we've been showing in other findings more than double the rate among care recipients under 60 or under, their caregivers reporting needing but not receiving mental health treatment, over a third of those. And the reasons, very high rates of time, the hospital or medication concerns, and then also quite a high rate, almost two-thirds, of just not knowing where to go for help. So that also speaks to that idea of educating service providers to connect individuals with needed mental health resources in addition to all the other resources they may require. Next slide. Another contrast that's important to keep in mind is the location in which the caregiver lives. And so it's all a function of how easily they can be connected to caregivers. We found that military and veteran caregivers to those caregiving recipients 60 and under are significantly more likely to live in rural areas compared to all other groups. Other groups tend to be about 15% rural, but among military and veteran caregivers to those under 60, it's 24%. So about 9 percentage points higher. We did not find statistically significant differences between urban and rural caregivers in terms of the outcomes that we studied, but one thing that we observed differed a lot or sorry, not the outcomes, but the characteristics, the barriers and challenges that they face. One thing that did pop as a meaningful contrast was home internet access. So, among our urban caregivers and caregiving recipients, only 16% report having no home internet access connection. Among the rural caregivers and recipients, 24%, almost a quarter. So that's 8 percentage point higher. And that can be very isolating, particularly I mentioned earlier telehealth services. Not having home internet access is a major barrier to being able to take advantage of telehealth services. So any kind of service programs that are provided through that modality may not be able to reach some of these rural caregivers who we also find in other ways to be higher risk and perhaps higher, more urgent need of those services. Next slide. We provided some recommendations similar to previously for to address these unmet mental health needs. One of them is the collaborative care model, which embeds mental health support services and into primary care settings through evidence-based care protocols. Telehealth, to some extent, can help address this with that caveat of if homes don't have internet access, they might not be reached by that or asynchronous counseling. So that can address the time barrier of, maybe counseling that can take place more flexibly, doesn't necessarily always require the care provider and the recipient to be on a synchronous Zoom call or something like that, might make treatment more accessible. Other options as well, like mobile health applications or a task sharing model, could also help for those who are concerned about hospitalization, and potential impacts on the needs being met of the caregiving recipient in the household. Next slide. So next, we're going to turn to creating more a caregiver-inclusive healthcare system. Next slide. According to our data, most caregivers do not feel supported by their healthcare teams. Only about a third feel that their providers listen to them or seek out their input proactively. And even fewer, 22%, told us that healthcare providers ask caregivers about their needs. So stepping beyond just the caregiving recipient, but checking in with the caregiver to make sure that their needs are met, we find that less than a quarter of cases report that already occurring. Next slide. But caregivers often figure it out. When we published our report, this quote that I'm showing on the slide here really resonated with many caregivers. A friend who was caring for a veteran who served in the post 9/11 era told us, when I started using their terminology, that was respected. I had to do a little bit of reading and research, And then it's like I taught myself, let's try this way, let's use their terminology. And when I did, then I got the respect from them where they would talk to me. So this is an idea that like if you learn to speak the language of the care providers, that can be a way in to become more engaged. It's also relevant to point out that some caregivers come to this more naturally because they themselves have a background in occupations like nursing or counseling services or anything like that that would already give them that terminology. For caregivers who don't have an existing background in that, that might be more challenging, require more effort, which we already know from the other findings they have limited time to dedicate. Next slide. So we main thing we emphasize here is that healthcare systems need to be incentivized to integrate caregivers into healthcare teams. So we recommend research first to document the value of integrating caregivers into healthcare. This could be measured in different ways, like shorter hospital stays, fewer medical needs, or improved survival and quality of life among caregivers who receive these supports, who are incentivized to receive these supports rather than not. Value could also be demonstrated through increased demand as families choose to receive care in more caregiver-friendly settings. So for the care providers, it can also be kind of economically aligned to provide these more caregiver-inclusive services. Second, we also recommend that policymakers consider additional billing codes, CPT codes, or codes used in medical settings to provide to identify procedures and services that would provide monetary incentives to providers for consulting with caregivers. So currently, one of the barriers to providing those services may be that there is no reimbursement mechanism. If there are no charge codes that providers can use to be compensated for the services they provide, it's more difficult for them to provide them. So that could be another policy lever to get rates of particularly providing direct support to the caregiver alongside the caregiving recipient to be increased. Next slide. So our final recommendation is a call for more research. Today we've talked about much of what we were able to do in this study, and we feel that this provides much needed data, but there are a few issues that we think warrant increased research focus aren't entirely answered questions by the existing work. Next slide. So one thing that we found was that the most common caregiving tasks are not considered activities of daily living or ADLs, nor are they instrumental activities of daily living or IADLs. So these are official kind of categories of activities that are sometimes an eligibility criterion for certain services. And so these that means that any policies and programs that only support caregivers assisting with ADLs and IADLs might have limited reach and miss these caregivers that are engaged in demanding and challenging caregiving activities, but just do not meet this particular criteria. Also, just these, so what we're showing on the slide here is that two examples of particularly common activities, especially among those providing care to those 60 and under, are remembering what the care recipient should be doing. So this is particularly relevant in terms of cognitive disabilities and other challenges that require care. And then also from the mental health perspective, coping with stressful situations or avoiding anxiety triggers or antisocial behaviors. More than half of care recipients 60 or under, their caregivers report engaging in that caregiving activity, but that would not qualify as an ADL. And these are just two examples. So one thing that we take away is that even more research is needed to not only address these potential gaps in supports, but also articulate the full spectrum of other tasks, whether it's providing care to those with mental health conditions, substance use disorders, traumatic brain injuries, cognitive impairments like dementia, there's more to learn on that front. Next slide. And this probably for this audience, this is not, you would already agree with this, but just something to emphasize is that even though those activities may not be categorized as ADLs or IADLs, what those caregivers are doing is very important and it matters. So take, for instance, the caregiver to a post 9/11 Army veteran who told us, here at home, I have to have all his medications locked up in a safe because he has tried to take his life before. And one of the things he has done that with is medications. My biggest challenge is to make sure that he doesn't try to take his own life again. Caregivers like this person have taken on an enormous caregiving duty, as have most military and veteran caregivers, and they should be recognized and supported for taking on these difficult tasks. And it's important for policy to be designed in a way that facilitates that. Next slide. So one thing, positive kind of angle to take on this, there are also benefits of caregiving. We've talked a lot about the struggles that can be associated with it. But we did also ask on our survey about the benefits, the positive impacts of caregiving. And there were high rates of reporting these benefits. So time spent caregiving can be rewarding in terms of the relationship that they have with their loved ones that are receiving those caregiving supports. Duration is also associated with this, and also helping with at least one ADL we found to be associated with greater personal gains from caregiving as well. So while there are certainly challenges, there are also benefits to both the recipient and the caregiving provider. Next slide. So, like I've said before, this is a long-standing line of research that RAND has been engaged in, and there was immediate and accumulating impact, not just from this 2024 report, but also dating back to the 2014 report that originated this, and even before then. So, just months after the results of this research were released in fall 2024. The Senator Elizabeth Dole 21st Century Veterans Healthcare and Benefits Improvement Act was signed into law. The results of this research were briefed before Congress. That's a photo on the slide of Dr. Ram Chand, who I mentioned is the lead of this effort, testifying before the House of Representatives Committee on Veterans Affairs in 2024. And we briefed these results across the ecosystem, including this webinar today. Next slide. So just final note, takeaway on the Rand Epstein Family Veterans Policy Research Institute. It conducts research that improves the lives of those who served and those who support them. And so if you want more information about VPRI beyond the work that has been shared with you today, I think Chantel has provided links to those resources. Definitely eager to share that more broadly. It's a lot more than just what was shared with you today. So thank you all for your attention and for supporting America's military and veteran caregivers. And I'm happy to answer any questions that have come in at this time.
Thank you so much, Dr. Hyde, and thank you, Daniel, for that amazing presentation and breakdown of the data there. I think there may be a couple of questions in the chat for you, Dr. Hyde.
Mhm.
So I'll let you take a look there.
Yeah, I'll answer them reverse or chronological or how they came in. So question, is this capturing caregivers for temporarily injured or disabled active duty service members? I'm interested in whether perspectives from caregivers for people on LIMDU, et cetera, were captured. So my understanding, because we included kind of the broad net, it would be inclusive of that. I would have to go back to the report of the survey instrument specifically to know if we had questions in the survey that allowed us to particularly break out those subgroups. But I guess the short answer would be yes. Those individuals, if they responded affirmatively to any of the tasks, any of the 7 tasks that we use to categorize caregiving, and also self-reported relation to a military or veteran household member. So that would be inclusive of active duty as well. That's also why throughout the reporting of the findings, I said military and veteran because it wasn't scoped to exclusively veterans. It would also be inclusive of those currently serving. And that I know we have some breakouts. I didn't share them in the presentation, but there are some breakouts in the published materials that focus just on actively serving caregiving recipients as well to see any contrast that emerge there. So, second question, providing support for caregivers is long overdue. What is the feedback from caregivers regarding ease of access to the services and benefits? So, this was a really strong theme that we pursued in the more qualitative elements of the project. So, with the disclaimer that I'm a more quantitative economist person, not necessarily was directly engaged in those activities, but I can still speak to them and hopefully do justice by the excellent researchers that we had on our team who were doing those interviews. There were different perspectives that we gathered. There were site visits included within this project where they went to VA facilities, they went to caregiver support groups and other services that are being offered, different sites that were selected for various reasons that are documented in the report. But I think a lot of the findings, definitely that quote that I shared in the slides about the quote unquote language barrier between not literally language, but terminology. The a big challenge to accessing supports is just really that respect issue of if an individual doesn't know kind of the lingo of healthcare settings, that can be a barrier to really getting access into those rooms, becoming part of the conversation that may then lead those supports to be provided. And I think in addition to what I shared about that quote, there were also conversations with caregivers that highlighted asking. So you don't necessarily have to know ahead of time what the terminology is in every case. That is one way that they can kind of glean respect and maybe be treated a little bit differently. But also we had caregivers who reported that just asking questions, saying, "Look, I'm not familiar with this terminology. Can you explain that to me? Can you reword that or say more about what you mean by that?" In many cases, the providers are happy to provide those details. They just might not do so unprompted. So being an active participant in those discussions, I think is another important thing. But there's so much more. I would definitely encourage following some of the links that Chantal has shared in the chat to see the full breadth of work because not even just one report. There were multiple kind of reports under the umbrella of this work that got into exactly those types of issues, the more qualitative elements of these needs as well. Um, so third question, and I see 2 messages. Thanks for addressing some of the positives of caregiving. We definitely wanted to emphasize that because while it is, important to talk about the challenges that are faced, there are very real positives that we were able to observe through our survey. And I think the question here asks for some more detail on this. So the question is, so where are the positives of caregiving documented? Caregivers with whom I have worked have focused on positives, helping person or loved ones, spiritual benefits, learning new skills, expanded social supports for themselves, dedication and commitment, respect, etc. I would say yes, all of the above. So, in terms of the specific things that we asked about in the survey, there was one kind of catch-all question that was sort of self-reporting. To what extent do you agree with the statement, I experience positive aspects of caregiving, or I don't want to paraphrase too much. I would have to go back for the exact wording of the question, but trying to get at, like, on a scale, how much do you believe as a caregiver that statement is true of your experience? And then we delved into more like item based, the specific types of benefits, and many of them are in the list that was articulated in the question. So certainly looking at learning new skills, the need to kind of step up and learn to do those things, because the caregiving recipient has that pressing need. Definitely the spiritual benefits, something that we also explored. The deepening of the relationship with the loved one, kind of the dedication, mutual respect, the just enrichment of that interpersonal connection, sharing that kind of vulnerability and that level of support. Definitely all found evidence of that in the survey's more qualitative findings. So again, kind of encouraging, just looking into the results of the report. There are many others on the team who could speak to those aspects a little bit better than I can, as a numbers guy. But definitely, yeah. I mean, all of the above.
Awesome. Well, thank you so much, Kelly, for answering some of those questions, and thank you to our audience for submitting those. I know we have a few minutes left. Of course, if any additional questions hit your mind as we do close out here, please feel free to reach out. Okay, and if we have time for one more here, Kelly, oh, a couple more. Okay, so they heard the final bell here, and a couple came in.
Yeah, no, I like
Okay.
it. I think it looks like one for me and then one for Daniel.
Awesome.
I'll take the one for me. What information has been explored and received in the area of respite care for caregivers? I do know that was um, specifically the one of the focal topics of at least one of the site visits that was conducted. So I would definitely encourage looking into that documentation. I think overall, again, kind of paraphrasing and aggregating at a high level, but our findings suggested that respite care where provided is very valuable. Caregivers certainly self-reported that. But the availability of it is limited. And I think particularly, and I'm going a little off the cuff here, so again, encourage looking at the report to really get the exact findings. But I think particularly for those rural caregivers, the more geographically isolated you are, the less likely you are to have access, particularly to those physical spaces that provide the respite care services. Certainly, and again, telehealth can help that to some extent, but because we see significant rates of households not having internet access, I think um, definitely a lot of unmet need out there, and that's another area for future research, figuring out how we can best expand access to respite care services, to different geographies and different populations. I think is a really important issue to address in the future.
Daniel, I think we'll close out with you here.
Sure. So the question is, with the data that I used, am I able to determine how many veteran households are multi-generational, where older veterans are needing to provide care and resources towards their adult children and grandchildren? And so the answer is that yes, the data does have a significant amount of granularity about family structure. So we can identify, particularly there's a relationship question. So the head of household is asked about their members, the people in the household, and whether or not they are their children or their grandchildren. And combining that with things like age, and we can even look at, what economic resources each member of the household is bringing, or what share they're contributing. We can definitely do that kind of analysis. Um, I think it's going to be, if you're looking at, for example, households where the head of house and their spouse are looking after their grandchildren, those are going to be a much smaller share of households. But the good thing about the ACS is that there's such a large sample. The probability of sampling a household like that and having several of those kinds of observations is good. So it can definitely start to give us some insight into those types of households, those multi-generational households. It's just we didn't do it for this particular study. Yeah.
Awesome. Thank you. Thank you, Daniel.
Mm-hmm.
Awesome. All right. I think maybe one more question came in at the very end, just around the average age of caregivers.
Yes.
Yeah.
Yeah, I was not sure. I can answer that live. I was also gonna type a response if not. But yeah, we do have a table in the report that gets into that, particularly the age of the caregivers. There was a lot of focus, and what I shared focused a lot on the age of the caregiving recipient. But in terms of the age of the caregivers, we found that like for example, just pulling a statistic from this table, among care recipients 60 or under, it's about 16% 18 to 24, 33% 25 to 34, 25% 35 to 44. So overall, I mean, younger, and there is definitely a correlation between the age of the care recipient and the age of the caregiver, but not perfectly one-to-one, because of that variation in relationship to the caregiving recipient. So I think if it was all spouses or strictly among spouses, we would see more similarity in the ages. But because there are children and grandchildren and neighbors who, could be of any age, there are really no strong reasons for a correlation either way there necessarily. We see a broad distribution of ages. So yeah, I think if table 1.2 in the report breaks it down by that age group, but that's the overall kind of qualitative finding, top level.
Thank you. Well, wire to wire, we had questions throughout. So again, I want to thank the audience. I want to thank our presenters, Dr. Hyde, Daniel, for a great presentation, digging into this data and really around our caregivers, which we know is an incredibly important topic, especially as we address our service members, veterans, and importantly, that family aspect. All right. Well, we're at the end of the half hour here. We have a couple just finalizing slides here to send you off with. So we'll head to the next slide here. And right, so here I mentioned this at the beginning of our presentation, but just to stay up to date with everything we have in terms of our technical assistance offerings, our webinars, learning communities, all of our technical assistance opportunities, you can do so by getting onto our listserv with our topics in the news. We have a monthly roundup we send out, and you can do so through that QR code there. You will be getting a copy of the slides along with the recording of the presentation, but you can also go to the SAMHSA.gov SMVF TA Center subpage. Next slide, please. All right, and thank you. Again, thank you to our presenters. Thank you to everyone for your great questions. And we look forward to seeing you at our next offering. Have a great rest of your day, everyone.